Alright, welcome back. I'm Army Pikett, and this is Blood Gas of the Week, case number 5. A 4-month-old male intact golden retriever puppy is presented for ongoing seizure activity. The puppy got into the owner's purse and chewed up a lot of things, including an entire box of sugar-free breath mints. The owners found him seizuring about 20 minutes ago and have come directly into the emergency room. They report he intermittently seizures for 30 to 60 seconds at a time and has not regained consciousness between the seizures. On presentation, the puppy's having a generalized tonic-clonic seizure that terminates as the owners walk in the door. The dog is hot to the touch, breathing very hard, and remains comatose. An intraosseous catheter is placed, blood is collected from the catheter, and resuscitation commences. As IV fluids are being started and dextrose administered, the following vitals and stat lab results become available. This one's venous, so we're going to move on to our acid-base interpretation. First, we're going to look at the pH. The pH is low, so this patient has an acidemia. Acidemia can be caused by a high CO2 or low bicarbonate. This puppy has a low bicarb, which means a metabolic acidosis. The compensatory process for a metabolic acidosis is a respiratory alkalosis, and it does look like that's what's happening. If you prefer the tic-tac-toe method, we see the pH is low, which is an acidemia. The CO2 is low, which means it goes in the basic column, and the bicarbonate is low, which means it goes over in the acidic column. Now we see which process lines up with the pH. In this case, it's the bicarb. So, the metabolic component is causing the primary disturbance. Our patient has a metabolic acidosis. The PCO2 is moving in the opposite direction, which is a respiratory alkalosis, so this is looking like we've got compensation. So, right now, we can see we've got a metabolic acidosis. It looks fairly typical, but sometimes there can be multiple processes occurring, and if we don't look for evidence of them, we can miss them. First step in looking for those hidden processes is to check the math for compensation. So, looking at our handy table, we see that when the primary problem is a metabolic acidosis, the formula says for every 1 point decrease in the bicarbonate below normal, the PCO2 should decrease by 0.7 points. So let's work it out. The normal bicarbonate is 20, and the puppy's bicarbonate is 14, so 20 minus 14 is 6. We're going to take that 6, because we said for each 1 point decrease in the bicarbonate, there should be a 0.7 decrease in the PCO2. So 6 times 0.7 is 4. And the normal PCO2 is 40, so we're going to say 40 minus 4 is 36. Now, not everyone's normal PCO2 is exactly 40, and not everyone's normal bicarb is exactly 20, so we're going to park our little range on there of plus or minus 4. That gives us a range for the CO2 of 32 to 40. And when we take a look, we can see that our patient's PCO2 is 30, which is not inside of our range. So in this case, the math doesn't quite work out. It's close, but it isn't there. Some people would say that calculating compensation is an imprecise science and that we're close enough. And others are going to say the math doesn't work out, so hands down, this is not a compensated process. At the end of the day, usually when you start treating the patient and recheck the blood gas in a little bit, these equivocal cases make themselves more clear. In this case, the metabolic acidosis is probably from the major muscle activity from the seizures, and then additional contribution to the acidosis from poor tissue perfusion. And then I suspect the puppy was breathing really hard after the seizure, which gave him a respiratory alkalosis on top of what his body was doing to try and compensate for the severe metabolic acidosis. So, our final diagnosis, we have a mixed acid-base disorder characterized by a metabolic acidosis and concurrent respiratory alkalosis. Oh, and resolution of the case. Some folks have wanted to know about case resolutions. So, this puppy was admitted to the hospital, resuscitated with IV fluids and IV dextrose, managed on a dextrose CRI until the effects of the xylitol wore off, and he went home the next day acting like nothing ever happened to him. So, thanks for watching. Keep an eye on the website. There's going to be a new page coming in the next few weeks that talks about assessing mixed acid-base disorders in more detail, including several different formulas to use to see if there's multiple metabolic disturbances happening in one patient at the same time. Until next week, keep the rubber on the road and the blood inside.